have to
Still,
make you a co-host again. Yes.
I have a problem with screen share. I need
Yes,
to.
yes. I have to make you a co-host now. Just a
Okay,
minute.
sure, no problem. So I don't know till where, but maybe we can start again. We tend to prefer to use modafinil as our initial treatment when children already come to us. Sometimes we will start with methylphenidate, but we see a lot of nervousness and side effects, even though it's frequently used. And so we prefer modafinil. Start with a low dose. We want to make sure that we avoid escalation and try to keep as much as the lowest dose that controls the best symptoms. We see, we define you're never going to normalize sleepiness in a child with narcolepsy. I want to make it clear, or with idiopathic hypersomnia. The MSLT will never be normal. But what you want is at least to double or triple the time. So if you have less than 5 minutes, you would like to get to about 12 minutes or so. Above 12 minutes, you're in a good range, and the same for any other. So repeating after you have maximized the dole and the symptoms are better, you repeat the sleep study and the MSLT, and you would like to see about 12, 13, 14, 15 minutes of sleep latency. That tells you that it's compatible with really what would be amount to a normal life. If the child has no cataplexy, you don't do anything else. If the child has cataplexy, then usually we start with sodium oxybate to control the symptoms. They will also improve the sleepiness. If not, we trend to go to venlafaxine, and the combination of the two can be used. If the child is resistant to modafinil and to the sodium oxybate, then we can add, usually what we do is this is when we bring the methylphenidate back into the equation. So we try to do, again, low dose and try to work, as you know, they work through different mechanisms. We have not yet experience with pitolisant, although we're very tempted to start it. And also we have no experience with solriamfetol since it's just been added as a new drug. But these are, and you can see that this review dates for only 1 year, but still does not include solriamfetol in its protocol. So I just wanted to point out that this requires patience, requires multiple MSLTs to quantify the quality and really the sleepiness in order to have as best a guide, in order also to minimize side effects of the drugs. And also the important thing is that added to all this, and possibly as the most important, is sleep hygiene. In other words, very regular bedtimes, very regular wake times, and also at least 1 nap a day in the middle of the day, not more than 20 minutes. We usually recommend 1 nap. Some kids can need 2 naps, particularly if they're younger, or when they go through adolescence. We give them 2 naps of 20 minutes each in order to really minimize the sleep pressure and adjust and be able to adjust for their ability to function through the day. So this is the diagnostic criteria for Klein-Levin. We have seen, probably in my career, I've seen, I believe, about 15 or so children with Klein-Levin. It's a rare condition. But when you see it, sometimes it is very fleeting in its presentation and not necessarily very regular. So you need to have a lot of awareness, which is why I mention it here, even though the likelihood that you will see one is relatively small. So the child needs to experience 2 or more recurrent episodes of excessive daytime sleepiness and increased sleep duration. And when I mean by increased sleep duration, 14 hours, 16 hours a day for days to weeks. This is critical. The episodes need to recur more than once per year, usually, and at least once of every 18 months. So you have an attack like this for 2, 3 weeks, then it disappears, then you have another one within 6 months, 8 months, 9 months, sometimes 12 months. Then you need to start thinking that this may be something called Klein-Levin syndrome. In between, the child is perfectly normal. Normal alertness, normal cognitive function, normal behavior, normal mood, okay? Now, one or more during the episodes, in the cognitive dysfunction, they really become unable to concentrate, unable to function. Sometimes they may seem even completely dumb. They're a child that is intelligent in school, doing fine, and then suddenly they are unable to function. Altered perception. They may have very strange ways of looking at things. They may either not eat at all, or they may eat like crazy. They are driven to eat, and they eat the refrigerator completely, and then may for 2 days not eat at all, and then again they eat the refrigerator. So or whatever you keep food, and they have completely disinhibited behavior. They may say very silly things, but most important, the one that has been described originally by Klein and Levine, was hypersexuality. This is mostly in boys, not necessarily always in boys, but mostly in boys. It's 60% or so are boys. And this hypersexual behavior can be very disruptive. And the child's symptoms are not better explained by any sleep, medical, psychiatric disorders, substance abuse, or medication. So you need to rule out all of these as part of the definition. So you can see that this is an unusual situation that you need to think of it. A very interesting study done on MRI and connectivity shows that there are multiple regions that have to do with thalamocortical networks that are intermittently activated. They also affect sleep-wake networks and also the ability to think and function. So the frontotemporal cortex, the temporoparietal cortex, which have to do with memory and executive function, are very dysfunctional during that period. Basal ganglia show this significant dysfunction and dysregulation. So either hypersexuality or thalamic due to thalamic, or perception due to the frontal eye fields being affected, as well as this excessive sleepiness, 18 hours, 20 hours. We had a kid that came from Saudi Arabia to see us, and this child had 30 hours in which he slept continuously. He would then wake up and become very sexually aggressive. He was 14 or so at the time that he came to us. He would become very, very sexually aggressive, very disruptive, say very many things. And then in between, he was the nicest kid in the world. Such a difference. You wouldn't believe that he would behave that way. And he was really out of control. So this is just to give you an example of how these children can present. And finally, just to reiterate the issue of insufficient sleep, you can see here, this is a 12-year-old that was seen in our clinic with, again, the late phase. It's just started puberty, and you can see that this child would go to sleep at around midnight, clearly insufficient sleep. This is why he came to our clinic. He had simply insufficient sleep related to the late sleep phase, and simple modafinil with some light exposure and commitment from inside resolved the problem very easily with him. So what I'd like to thank you for your attention. I appreciate the opportunity of speaking to all of us, to all of you today, and tell you that I'm happy to attend to any questions. Obviously, there's nothing better than to see the sunrise in Missouri with a tree that looks like a heart. So all my love from Missouri to all of you. Thank you very much.
Thank you, Dr. Goza, for this amazing lecture. Sorry again for the inconvenience that we had. So fortunately, I wrote down the questions before losing the whole Zoom. So the first question that we had in the chat section was about your idea on sleep hygiene in toddlers and infants. So
regularity. Let's start with regularity. Sleep hygiene, what the mean, I don't like the term of sleep hygiene. I have no better one, but I think that what we need to do is remember that most children that have difficulty, bedtime resistance, you've heard it from Dr. Medali, the person that pays the price is the parent. Children at age 2, 3 don't have schedules. This is why they're so happy. The moment that we start putting schedules into our lives, this is when we start becoming unhappy. And the more we go, the more unhappy we get. No, just kidding, just joking. The important part is really that we need to establish the rules of engagement and make sure that they are as rigid, if you wish, with some tolerance. We need to accommodate. This is life after all. But we need to make sure that regularity is part of the expectations. Why? because this is something that many sleep experts, many years, have called sleep entrainment. So what it does is that your regular scheduling trains your brain and your clock and everything else to align into the system. And once you're very aligned, it is very easy to fall asleep. It is very easy to maintain a schedule. But if you start creating irregularity, then our biology does not know what to do. So before we start talking about any pathology, let's talk about what parents need to understand so that they realize that they are the ones that are driving this issue to their children. It's not, don't expect what I call a magic potion, which is what most parents come with. Oh, doctor, give me something for my child so that I can sleep. Because he doesn't want to sleep. He bothers me. He comes to my bed. He shouts. He cries. He doesn't want to go sleep. Well, establish first a set of rules, impose them. After all, the parents are supposed to be the boss in the house. It's not the child that rules the house. It's the opposite. But that's I think, a major issue. So I again would like to emphasize that regularity is really very important in order to achieve the kind of what I call happy parents because of their happy child.
Thank you, Dr. Gozal, for this, for your explanation. So the second question that I wrote down, actually, they repeated the question. So the treatment plan sometimes becomes an issue in child when the child mind is overloaded, for example, during school examination period. So how to re-engineer that plan?
So we all know when you have worries, right? Anxiety, worries in life, it is difficult to fall asleep. Your brain is hyperstimulated. So there is, as you probably heard from, I think that there is a lot to be said about stimulus control and cognitive behavioral therapy as ways of engaging and relaxation techniques. And there are multiple things that have to do with wellness, yoga, thoughtfulness, and mindfulness, and so on, that can be very helpful for children. And I think that training children to address issues of anxiety or issues of stress are very important. Let's not ask for physicians to solve everything with medications, but rather let's use very significant techniques that have been developed all over the world in all different cultures. You have Duke as part of your, but the reason I mention it is because yogurt has been known for many, many years to change the microbiome. And we know that it changes the microbiome. It actually brings a variety of metabolomic products that are actually sleep inducers, natural sleep inducers. So we all know that if you drink yogurt, you are more likely to have more relaxed, feeling more relaxed. Well, that well-being, it can be induced also through mindfulness, through yoga, through exercise. Good exercise, high intensity exercise can be reduced this sense of stress or anxiety. So let's use normal things rather than resort to medications. I think it's a very important component.
So in relation to what you were saying, so we had another question about the effects of probiotics in sleep improvement in these patients.
Yeah, good question, and one that there's not yet. Dr. Herandish is now leading a major effort where we have started randomized control trials. We're about to launch one in sleep apnea, another one in sleep. But we are we have been doing a lot of work in the last 10 years on the impact of microbiome on sleep and the impact of sleep on the microbiome. So these are two-way street, right? And I think that what we need to understand better, and this is really just before this conversation, we were talking to a collaborator, that really how do we identify the children that would benefit and what is the benefit that we want to give them. Please remember, all of us have very, very personalized microbiomes. And so there may be that there's not going to be a lot of effect if you already have all the good things and you have a problem of sleep. Then giving all the good things, then the microbiome is going to be useless. And then you're going to say, well, the microbiome doesn't do anything. Well, in that particular person, is not going to do. So I think that, there's nothing wrong about trying it, but don't expect miracles either. To again, if you use a gummy bear with lactobacillus and what have you, bifidobacterium, don't expect that within the 24 hours the child is going to go from one who doesn't want to go sleep and has all these behavioral issues to one that sleeps like a baby and lets you have all the evening for yourself. It's not going to happen. Okay, so there's a combination of things that you need to do, and but I believe that there might be a role for probiotics. I believe that as we understand more about it, that it needs to be tailored to each individual patient, and it is that personalized approach that we're seeking to develop and to optimize.
Mhm. Thank you, Dr. Gozal. So, before continuing with the rest of the questions, I'm just going to ask our audiences to start. If you can, please start your video so we can take a group photo at the end of this chat and Q&A. So, Dr. Gozal, the next question that was written was about the melatonin dosage that we can use. So, they were asking, for delay phase, can we give the patient 1 milligram of melatonin before DMI in order to increase melatonin sooner? Can you explain about the dosage a bit more?
Yeah, so good question, because there's really no standard. First of all, most of the melatonin that is provided across the globe is not standardized. So there's a problem if you don't know what potency you're getting based on the product that is done under uncontrolled conditions. So that's problem number one. So it's difficult to say start with a dose. I believe that the best dose is the one that works, right? That's what they taught me in pharmacology. Uh, One that works without side effects. So that's really what you want to achieve in any type of intervention that targets sleep induction, or at least the what I call opening the gates of sleep. As you know, melatonin does not induce sleep. It opens the gate. It facilitates in the motivated individual to go to sleep. So it's like opening the door. You open the door and says, Befarmait, come on in. But if you don't open, if you at the end, when the melatonin comes down, the door closes, and now it's much more difficult. And you all know that from your own lives. Um, at 9 o'clock in the evening or 10 o'clock, you're going to feel very sleepy. If you resist and stay awake till 1 o'clock in the morning, at 1 o'clock in the morning, you will be much more awake than you were at 10 o'clock in the evening. Well, that's because your melatonin now, your natural cycle, has come down, and now you have a lesser melatonin in your body. So you could stay awake. You managed to stay awake. So melatonin is not going to do everything. It opens the gate and says, please come on in, sleep, come on in. If you are willing to receive sleep, then you will have easier time to fall asleep. So that's issue number one. So the doses, we usually start about an hour before the desired bedtime if there's no other things. So about 1 milligram or 2 milligrams or 3 milligrams, depending on the size. Younger kids, less than 6, we start with 1 milligram. Between 6 and 12, we start with 2 milligrams. And then after that, we start with 3. But we have seen kids that at age 5 that we have given 6 milligrams, not more than that. By the way, Professor Daniel Cardinelli was an extraordinary scientist in the field of melatonin in Argentina, in Buenos Aires, a very dear friend of mine, has done very very seriously high doses of 50 milligrams of melatonin in a single dose with absolutely no side effects. Okay, we absolutely no real bad consequences. On the contrary, it has been used as a protector of the brain and as for conditions that obviously very pathological, as an antioxidant for the brain and as a neuroprotectant. So I hear sometimes, oh, there was all these consequences of side effects. The majority of side effects are minimal. Some GI disturbances, because we know that it affects the GI system, some degree of bloating, some constipation. Those are the side effects of melatonin, really, not more than that. So anything else, I'm sorry, I don't believe that it's related to melatonin. So you can be quite liberal in the dosage that you start, but as I indicated, starting with a low dose and then escalating as needed, provided that you know from diaries or from actigraphs that the parents are also doing their part, because many of them will tell you that they are, but they really aren't. So let's be real, okay?
Thank you. Thank you for this explanation. So, the next question that I wrote before losing the Zoom was that is there any relationship between narcolepsy and any other autoimmune disorders like Hashimoto thyroiditis? Thyroiditis.
Excellent question, and the answer is yes, but not examined as thoroughly as it probably needs to. As you know, there's been an association between that and flu vaccine, particularly the one that was used with enhancers in Finland. And so we have seen also, we are doing Professor Sima Kadron-Boone at the University of Cincinnati and Cincinnati Children's. It was one of our dear fellows many years ago, but now is obviously a renowned sleep specialist on his own right. He has been leading with many of us a multi-center study of narcolepsy in children across the United States, where we have collected information and database over 1,000 children with narcolepsy. And what we saw looking at the onset of symptoms, that it also coincides more in the winter associated with influenza. So there might be some elements of viruses that could trigger an autoimmune transformation that then leads in the susceptible individual with the appropriate immune system construct, genomics, to be at risk. And that's why I alluded to the three polymorphisms in genes that are all involved in the immune system. Both T cell biology, particularly CD8 positive T cells, but also related to TNF constructs, et cetera, et cetera. So that is one area that we're not clear, but the association with other autoimmune disorders is difficult because they may have different temporal appearance. So let me explain. So when you look at the population of adult patients with narcolepsy, there is also an increased prevalence of autoimmune thyroiditis, Graves or Hashimoto, but there are also additional autoimmune phenomena. So the link is not very well established because the time of appearance may be very different and may reflect either coincidence, is it just because of the vulnerable immune system genomics and therefore they coincide, or do they relate to each other? This is a matter for really under debate, and with Professor Mignot at Stanford, we've had very interesting discussions about this.
Okay, so thanks again. So the next question that I'm seeing in the chat section is about the youngest age to start for KLS, and can it be started at 3 months old, a periodic hypersomnia?
No. The periodic hypersomnia in very young age, and you need to look at other conditions. KLS is not. So look for, CNS disorders that may or may not be clear. There could be subcortical seizures that you need to think about, tumors, other abnormalities. And if you don't find anything, then sometimes you have very idiopathic cyclical hypersomnia that occurs but it's very difficult. If a child needs to sleep at 3 months, 14 to 16 hours a day, how are you going to establish that there is really, unless they sleep for 24 or 38 hours, how can you establish this? So I would put a very significant question mark to the occurrence. But Klein-Levin has been usual peak is about age 14 to 18, with a second peak around mid-adulthood, so young adulthood of 25 and above to 35. Those are the two peaks that we see, the big peak in the adolescent, the second peak, smaller one at about the mid-20s to early 30s. Those are the two peaks. Very, very rare. I don't recall that we have ever seen a child with Klein-Levin that was younger than 11 years old.
Mm-hmm. Okay, so thank you. So the next question that I'm seeing is that could gut-brain axis affect narcolepsy conditions, and would it be possible to ameliorate the symptoms by altering the microbiome?
So it's the same that we were talking about
Yes, yes.
in a way. So the gut microbiome, gut-brain axis is obviously, we have learned now that everything is connected to everything. We tended to become, when subspecialties were developed, we were very, very proprietary of our own organ. of interest, right?
Mhm.
So we became lung specialists, heart specialists, endocrine specialists, gland specialists, et cetera, et cetera. We've come to realize that every organ is connected to every organ again. And the brain is connected to everything. So there's a cardiac or heart brain. The heart brain is important. The lung brain is important. Axis. The gut brain is important, and many others, right? And so one aspect that we need to understand is that it's not just the gut microbiome that may be, for example, in acne, there are substantial changes that occur in the skin microbiome. And so if you disrupt the skin microbiome, the propensity for acne can vary tremendously on fluctuations of the microbiome. And if you stabilize it, you may control many, many of the acne phenomena. The
Mhm.
same is true for the oral flora. It's not just about the gut. It's the whole, oral, pharyngeal, intestinal system all the way. And so we need to talk about the lung microbiome. We need to talk about other microbiomes. Even there is evidence that the brain itself may have its own very reduced but nonetheless present microbiome that we are just being detected in one paper in Science about 3 or 4 months ago showed that there might be unique particles of microbiota that may be very important for brain homeostasis. So I think that we are still beginning. The microbiome, by the way, one that we don't talk about. So all the mycology related is also very important in regulating the viral biome, which is also important to the bacteriome. So there's a lot of interactions between all of these, and we could spend hours just talking about this because it's fabulous. But
Yeah.
remember that 99% of your DNA, 99% of your DNA is bacteria, is
Mhm.
microbiological. Okay, so all of us, it's only all the actual DNA that really belongs to us is 1% of our total body. All the rest is really coming from other living agents.
Okay, so uh, I'm going to apologize from everyone because we don't have more time. I'm just going to read another question, the last question. And before that, I'm going to ask again. So everyone, if you can, please turn on your videos so we could take a group photo after this Q&A is over. So the last question I'm going to ask is about the relationship between narcolepsy and cardiovascular diseases, and which type of narcolepsy mostly leads to cardiovascular problems.
So the connection between narcolepsy and cardiovascular function is not yet fully established. There is some evidence that long-term narcolepsy may be associated with unique features that are very difficult to separate. Remember that many of the narcolepsies will gain a lot of weight. So is it because of the weight or is it because of the actual narcolepsy? First question, we don't know. Second, we use a lot of medications that are stimulant medications, and these could have impact on blood pressure regulation and dysregulation of the autonomic nervous system. So that's another. So there's still a very significant question marks being asked as to whether, that there is over time an increase in the cardiovascular component, the morbidity is true. But the explanation for it is unclear as to whether this is proprietary to the narcolepsy disease itself or whether it's just another manifestation of all the other surrounding consequences of narcolepsy, both related to obesity and its consequences, but also to the medications that are given.
Mhm. Okay. Thank you again, Dr. Gozal. I'm seeing a lot of questions in the chat section, but we really don't have one more time. So I'm so sorry I apologize that we cannot ask them all. So thanks again, Dr. Gozal, for joining us.
Thank
And
you.
I'm going to ask everyone to turn on their video so we could, and smile, so we could take a good photo, a group photo this time. And after that, we will just finish this session. So I'm going to give 30 seconds time. So keep smiling in this 30 seconds. I'm going to take different shots, hopefully, and choose a good one. This is so amazing to see so many smiling faces. This is really great. Okay. Thanks, everyone. Thank you. The pictures are amazing. Okay, so Dr. Modari, see if you want to add anything to this lecture.
Thank you, Professor Gozal, for your amazing lecture. Thanks everyone for joining our events. A special thank you to all of our distinguished lecturers, especially Professor Gozal and Professor Khairandish Gozal and other Missouri team. Hopefully, we can meet you all in the advanced course, advanced part of pediatric sleep disorders. The second part or advanced part that we will be announced in near future will cover the advanced topic of the sleep disorder in children, such as interpretation of polysomnography and consideration when undertaking non-invasive ventilation in children with disability, movement disorders, and NIV titration. Again, thanks a lot from Professor Gozal. David, a lot of thanks for your
You're most
cooperation.
welcome. My pleasure, and very delighted that we could work together on this wonderful symposium and course. I hope that it was helpful, that it stimulated the appetite for more. Ultimately, the source of knowledge is really when there's appetite to learn. You never can learn without wanting to. That's another element. It's like sleep. If you don't want to sleep, you can stay awake. If you don't want to learn, you don't learn. But I appreciate the interest. I'm delighted to see so many wonderful pediatricians and other colleagues who are attending this course. This is obviously a wonderful success. And I congratulate the University of Tehran and all my colleagues who really collaborated so nicely and initiated this encounter. And let's hope that we will continue this as a tradition for the many years to come. Thank you so much.
Thank you so much. Bye.
Thanks, everyone, for joining us
Thank
again.
you, everyone.
Thank you. It was really an honor to have you guys with us. Hopefully, we will see you in the advanced course, as Dr. Modaresi said. And hopefully, we will have our foreigner guests and our audiences here in Iran. We could serve you some chai or whatever you would like. Hopefully, in COVID-free days. I'm seeing a lot of babies in the pictures. Oh my
Yes.
God. Kisses for the babies. And
You're
have a
welcome.
great night. Goodbye.
Good night.
Bye.
Bye-bye.
Hadi.